Hello, welcome to UMC EMS. Once again, my name is Chad Curry, the training chief at UMC. Today we want to talk about expanding our ketamine protocols. We're adding ketamine. We've been using ketamine now for about a year, and we want to expand that into a little bit further usage that we're going to be using in our protocols here. So today we're going to be offering a CE that'll be 0.75 hours in preparatory for the state, and it'll also be 0.75 hours for airway, breathing, and circulation for National Registry. So as we begin, we want to start talking about, right now the primary uses for ketamine that we have is using it typically for combative patient and for entrapment protocols. And at the entrapment side, we're using it at a very low dose of 0.5 milligrams per kilogram. And as what that accomplishes is a mild sedative, but mainly controlling the pain that we're going to be giving that patient while we're extricating them, and allow us the ability to be able to control them a little bit more in a stable environment. The reason why we like to use ketamine here versus Versed is the great reason of that ketamine's typically going to let them breathe the whole time. We don't have to worry about that apnea quite as much as we do with Versed. At the same time, on our combative patients, especially with our synthetic drugs that are on the streets these days, the ketamine goes to 2 milligrams per kilogram IV and 4 milligrams per kilogram IM. Is what that accomplishes is the true dissociative effect that ketamine offers us, and that gives us the ability to safely secure those patients and to provide care for them and help with the excited delirium and be able to calm them down to where we can care for them. So as we talk today, first of all, we're going to give it a good review, give ketamine a good review of how the drug works, why the drug works, and then we'll move into how we're going to be using it. So some of their objectives today we want to examine ketamine and the actions on the NMDA receptors and the opioid receptors. We want to talk about and gain an understanding of how the medication provides dose-specific CNS effects, so how it's going to affect us with our central nervous system. Understand the benefits of ketamine with different disease processes, because we're going to be expanding it into a respiratory side, and so we need to understand what that's going to do for us, along with the side effects of ketamine. We also want to learn the adverse effects of ketamine and the cautions that we need to take to use it. And last but not least, we want to explore the expansion for UMC EMS of what we're currently going to be using in the later part of this year for 2015. So let's understand ketamine. You kind of got to be one with an NMDA receptor. And so we talk about this because, guys, we start breaking these drugs down, and it is so important to understand how the drug's working if you're going to be the one administering that drug fully. And that's something that we don't always get a lot of in our paramedic school, because there's so many drugs on the market these days, it's hard. So when we get to our service, we need to very specialize in especially the drugs that we carry. NMDA, first of all, is an amino acid that is derived in the function of the glutamate. And what that does is it excites neurotransmitters. And so it allows our neurotransmitters to get started and get going. And if you remember, we talked a lot about glutamate when we were talking about our seizure control and talking about using our benzos. So what usually is happening is these neurotransmitters are getting a tug of war with our glutamate and with our GABA receptors. And we talked a lot about the GABA receptors because that's where our benzos come into play. That's where that benzo comes in and it blocks that GABA receptor. And if you'll remember, the glutamate, the neurotransmitter, actually promotes that seizure activity. That is what that is designed for, is to promote that stimulation of the neurotransmitters. The GABA tries to prevent that rapid firing of those neurons. So that's where we come in with our benzos, as we try to, in our benzo drugs, our benzo and agonist drugs. So we use those on the GABA side to put a block on there to where they don't fire as fast, and that's what stops our seizure activity. And this is all going to come together. I know we've kind of switched back and forth, but the glutamate becomes very important here. So like glutamate receptors, the NMDA receptors allow more positive charge ions to come across the cell membrane. These cells are increase the potential of depolarization. And so they're able to, that glutamate actually goes in there and promotes that firing. It promotes that to get it going quicker. And so on that side, they use the MADA receptor. That's where that glutamate gets absorbed in right there. And so that's what the whole part of that ketamine is we got to understand ketamine is an antagonist to that MADA receptor. So let's first talk about pain, because that's going to be our first big expansion. So how does ketamine work with pain? So why is glutamate important in the pain series? As you can see over here, you've got pain, then you've got increase in the glutamate receptor, or glutamate, and then you move into the NMDA receptors, and these get activated, and this is a natural response, and then the pain takes off because now these cells are firing quickly, and they're saying, hey, I'm hurting, and I'm hurting right here. And so they start to fire very quickly. One of the biggest things, pain stimulates more glutamate to be fired off. And so our body starts to produce more of that to say, hey, I'm hurting. And so the MADA receptor starts receiving that more. As it receives it more, we know the glutamate causes those cells to fire quickly and to depolarize quicker. So they're saying automatically, hey, right here, I'm hurting. And I'm hurting very bad. And so part of this process is we can come in with the NMDA receptors and we can start to affect that. Elevated MADA receptor activation, well, we know the glutamate from the pain, right here, starts that, and then all of a sudden the MADA receptor says, okay, I'm active here, come on in, I want you all to come in very quickly. And so part of that is they also do have, the MADA receptors also do have some effect on the opiate receptors. Well, currently in our pain management protocol, we're only treating on the opiate recepting side. And so we're going to add another, think of it as another layer to that protection of how we're going to stop that pain. You may see this effect in morphine as it will just barely touch the pain sometimes. So you get somebody with a traumatic injury like this is a full, basically degloving of the lower leg, you know, astronomical amounts of pain right there. And so us giving them just a little bit of, you know, giving them even a larger dose of morphine, we're only treating on one side of that receptor. You see cancer patients all the time that have breakthrough pain that they can't get controlled. And so in a double-blind randomized study that was pulled, ketamine was actually added to the morphine, and the patients did it in a double-blind, one of them receiving morphine dose alone and then morphine in a placebo. And they're saying that with ketamine added, and they were finding that ketamine added to that was adding to a separate receptor. So you have both of those receptors working and stopping the pain, the breakthrough. So the ketamine, so let's talk about what it actually is. It is a NMDA antagonist. So that tells us that it's going to go in and bind to that MADA receptor, and it's going to put a block, and it's going to say, glutamate, you're not going to come in today. It's not going to work right now. And so we're putting that extra layer of blockage on top of what our opioids would already be doing on the opiate receptor side, and that's going to stop that vicious cycle, and that's where we come in right here, and we're doing that MADA receptor blockage right here. And so we're still making the glutamate, our body's still making it here, and then we come across and we're going to block it to where it's not received, and that will start to bring that pain management into practice. So how does ketamine fit in this picture? Ketamine is a strong analgesic for severe pain management. The good thing is we got a little bit more benefits. It decreases vascular resistance. Well, a lot of times, you know, when people get excited, they're dumping histamines through their body as they're hurting. We may have some vasoconstriction from that. We actually get bronchodilation from ketamine with those patients. It also remains hemodynamically stable. We don't have to worry about hypotension. It's a very, very low risk with ketamine. Now we do have to worry on the flip side of this a little bit of hypertension. And we know as we hurt, as we're dumping endorphins, we have epinephrine, norepinephrine going, that our blood pressure is going to increase some with pain. And so we do have to kind of weigh that, but at the same time we're going to get a lot more benefit, and we're going to talk about that more here further on in the ketamine study. Ketamine also sedates and dissociates. This gives us of course, this is why y'all are very familiar with ketamine right now, because we use it for the dissociative effect. At the same time, and we're going to talk why that works here in just a little bit, but that's also an extra benefit to it. It would be like you giving a little bit of fentanyl and a little bit of Versed together kind of at the same time, but I'm meeting both of those receptors with one drug. So pain management, once again, MADA receptor, ketamine. This prevents the positively charged calcium and sodium ions from flowing into the cells. This slows that natural depolarization. So those cells naturally aren't firing off. They're not accepting that glutamate and firing. And so they work on two different things. We have two different receptors that we deal with pain on the pain side. First of all, our MU receptors and then our delta receptors. The MU receptors, this is mostly on the opiate side. This is where our morphine, fentanyl, Demerol, and Dilaudid are going to come in and really help handle the pain for us there. On the delta side, though, this is the natural side. Okay, this is where my body's going to naturally produce those painkillers that's going to start to manage that system for us. To a small degree, some of our pain managements or some of our opiates will function on the delta receptors, but ketamine does as well. So we're kind of getting a double benefit off of that. As we continue with our pain management, why is the opioid receptors information important? Well, since ketamine addresses pain on the same receptors as the opioid, we just talked about that, and the adverse effect, it can give the adverse effect as the same way. Ketamine just gives us a smaller punch at this point, given that it's given in safe doses, and that's why we use that 0.5 milligrams per kilogram like we were using with that extrication. I still need that patient to respond to me, and so I know level of consciousness wise that I'm doing okay, but I need to be able to block that so I can manage, especially once I start moving that car off of them, and if I have a fractured leg, that's going to cause a lot of pain. This is going to work in the same way once I get them extricated, or if I get there and they're already extricated, so they slipped on a trampoline and they have, gross dislocation and possibly a compound fracture of the ankle. That's going to be a very big situation for me because I need to be able to manage that pain, especially as I got to carry them off of that trampoline or whatever may happen. So in saying that, once again, our ketamine goes back to, it gives us very minimal respiratory depression and apnea, very low chance of that unless the drug is given too fast. And we're going to talk about that more in the caution area. So as we move in, always remember that to double check your drug, double check your dose, double check the concentration, that I have the right patient, the right dose, the right route, and the right time. And then I'm ready to administer. Once again, on your allergies on that side, I've yet to see anybody with a ketamine allergy, but I'm sure eventually as ketamine becomes more popular, which it has been over the last year or so, it may be a little bit more prominent. When we are giving it an IV, just remember, do not slam it. This is not a drug that we want to administer very fast. We want to give it very slow. The literature states about 60 seconds is what we're looking for here. They're going to start to get that pain, but as I'm giving it, and I may have to give just a little bit, keep doing my thing, and then come back, if I'm very busy, just trying to manage that patient. So it needs to be given slow over time, and that severely reduces that chance of apnea. Okay. So if the MADA receptors are activated in the lungs and airway, so as we start talking about on the reactive, we're going to move over to the reactive airway disease side. As we're going to start using this for our intubations with reactive airway diseases and post-management care. So a lot of times, I may be in the middle of, I don't know the whole story right off the get-go, and I kind of, I get them stabilized. I may have to put a breathing tube in, and then the family says, well, yeah, he's been having respiratory distress for the last 3 days. Because, it happens to all of us. We get information kind of in the beginning and kind of during, and then usually a lot when we have time to all visit a little bit more after we've taken care of the acute problem that we're facing. So this would be a good drug for even post-intubation to go ahead and give ketamine. We get a couple of great effects from it. It's going to last a lot longer than our Versed is. Right now we use Versed and fentanyl for post-intubation care to keep our patients sedated, but ketamine is going to give us a little bit more time. We're also going to get a huge benefit from bronchodilation from it. So if I was having any respiratory problems, say if I see the sharp fin on my end-tidal CO2s, I get those directly fixed, not only with my nebs that I'm going to be bagging in, or my dual neb, but at the same time, I'm going to be giving them administration of ketamine, and that's going to help open up those bronchioles at that time. Ketamine may also, there's some literature that talks about reverse the histamine inducing constriction from the histamine drop, the histamine that's being dumped into the body at that time, and enhance bronchodilation through the beta-2 antagonist property. So we get a lot of different effects from our ketamine. So ketamine, we're kind kind of what you're hearing, kind of like the paramedic is a master of none, but we're a jack of all trades. That's kind of like ketamine's moving into. We're able to use it for a lot of different things and very safely at the same time pre-hospital, because it still provides us an airway at lower doses and then a long sedative at higher doses. But we want to make sure that on our reactive airway disease, we start off always with supplemental O2, use our dual nebs that we use here to get our beta antagonist on board. CPAP, early CPAP, I can't stress enough. We still have the ability to use Ativan and Versed there. We may actually look at a little bit of ketamine in the future using with CPAP. The only problem with, a lot of times it can drive a little bit of blood pressure, and CPAP's going to kind of lower it. So that may be a good benefit there versus my Versed may be a little bit heavier and I may have a little bit more apnea. So I think most people are using Ativan for that as their benzo of choice to keep to make them CPAP compliant, because that's what we want. And then last but not least, we'll make sure we get our steroids on board, our Decadron on board. However, with respiratory failure, once again, ketamine can offer additional support for these patients hemodynamically and bronchodilation post-intubation and for intubation. So let's talk about that, maintaining the hemodynamics, because that becomes a very big part. We see a lot of times, we'll get these patients intubated. They may not have enough blood pressure to give them something post-intubation. So, we may get them get a PAI performed, get a secure airway in. We've got great end titles, and their pressure's still 60. But at the same time, you're getting them oxygenated at this point, and they're able to, they're starting to bite on the tube. You're starting to see a clear clef on your end title. You may see the tearing, you may see increased heart rate. And so right now our hands are kind of tied, because the only thing we offer right now is fentanyl as our other drug of choice, which is hemodynamically stable, but it has no sedative effect. It's only an analgesic effect. And so this will give us the ability to offer that patient some a big sedative at that point that's hemodynamically stable. One of the big things that we talk about is our patients a lot of times that are in cardiogenic shock. The proper term for cardiogenic shock in the field, it's very hard to diagnose cardiogenic shock, but kind of how we measure that in the field is your wet lungs, so your CHF, or you're in heart failure and you have no blood pressure. Versus the other side is we have our just general CHF patients that we're going to CPAP, and I've got them hypertensive typically, and you're going to see that with those congestive heart failure patients, because they're trying to perfuse those lungs. They're kicking their pressure up, trying to get those lungs perfused and get oxygen where it needs to be. So this will give us a good time for our patients that we have to take their airway in the field, that we're in a position we don't have any other options. CPAP is not a choice, and we just don't have enough respiratory drive. We have to. So hemodynamically, this is sure going to help us on the cardiogenic side. So let's talk about how the ketamine works on the hemodynamic side, because this becomes very important. That once again, we understand an in-depth look at ketamine and why it works. So some of the stuff that it talks about, patients, it'll make them it make their heart rate go up a little bit. It makes their blood pressure go up a little bit. One of the hypotheses is, and there's not a lot of literature on why that ketamine makes it do that, but one of the hypotheses is that the neuroepinephrine is absorbed by the neurons, and basically ketamine comes in and will kind of block that. Remember norepinephrine, we have epinephrine and the norepinephrine, and so that's going to possibly give us the ability to block that neuroepinephrine from coming in, and so it's going to block that from being transferred over. So hopefully that's just one of the hypotheses of why we want you to understand why it's keeping that blood pressure driven, and that's one of the hypotheses for it. So as we looked at some studies, so this was a study done this is an older study, and it was a small study too. It was volunteers. They had 2 milligrams per kilogram to healthy humans first of all, and both those shines of catecholamine levels measured at 5 and 10 minutes post given ketamine. So all 3 of the patients that they studied here, the heart rate was noted at 5 minutes to be elevated and be even more elevated, and you can see all of them were about the same. Now This one actually dropped just a little bit, but you can sure see a spike in the blood pressures at about the 5-minute mark. So that's kind of at the 5-minute mark post ketamine. That's kind of going to see hopefully about the highest that you're going to see, and then we'll start to see that trending down. All three of these, once again, there was an increase in heart rate, so we've proven that, and that's been proven many times in many different studies with ketamine. So we know that's just something to anticipate. So what I'm saying is, if we've got somebody with a severe head injury, and we're already looking at 220 over 120, and that gives us a mean arterial pressure of 130s at that point. That's something I may want to look at. Really consider. Okay, this may be the good one for etomidate instead of ketamine post, and this may be a good one for maybe a little Versed. You kind of got to teeter with that because I still got to perfuse them. To perfuse a bad head, we want a mean arterial pressure between 90 and 110, roughly, for an active bleeding or severely injured brain. That's what we know that it takes to perfuse those. So in saying that, I kind of got to teeter with that. But at the same time, if I've got somebody that's a little hypotensive with a head injury, this could maybe give us a little bit of benefit of perfusing that. It's kind of a robbing Peter and paying Paul type deal. And so we just got to use your best judgment call on those. But we want you to understand, yes, it does, be very upfront. It is going to increase the heart rate. It is going to increase the blood pressure. Another thing on the heart rate side, I may have a patient with, congestive heart failure or end-stage heart failure. I really got to worry, if I give them this ketamine, is that heart going to be able to give me what I need? If they're already at 120 and I'm going to be giving ketamine and I know I'm going to be going up, maybe up to 12 points there, 24 points here, that's a pretty big increase. Is that heart going to be able to give that to me? So I kind of got to weigh all that together. Hopefully at the end of the day, but on that CHF side, I'm going to get a big bronchodilation. So once again, I'm going to have to kind of weigh that of how that's going to work. So there are some horror stories out about ketamine. So let's just get them out in the open. A lot of people have talked about ketamine post-PAI, people going into cardiac arrest. And so some of the things that we talked about, yes, we do know there's an increase in heart rate. We know there's an increase in blood pressure, and it improves bronchodilation. Okay. We've proven those facts today. But at the same time, some of ketamine's effect, once again, is it prevents the norepinephrine uptake, usually overrides these effects. In rare cases, cardiac arrest has occurred in these patients after depleting the catecholamines, the adrenaline and the norepinephrine stores of our severely ill patients or the maybe very stressed patients. And so you've all had those calls where nothing really went really smooth because the patient was so sick. They might have waited so long, or they became so acutely ill so quick, and by the time we get there, we're behind the 8 ball to start with. This is your patient. This is the one and that happens to us a lot, unfortunately. But they, all their catecholamines are eaten up. All of their adrenaline and their norepinephrines are already burned up. And so they've driven as long as they can on their own. That natural, the natural body's response of providing care for this is said, I can't do this anymore. And so using that ketamine, once again, does block that norepinephrine from being received back in. And if I'm already low in that category, then I could get myself into a little bit of problem. The general rule of thumb is always watch your patients for hypotension, and any patient, or after you've intubated them, no matter what drug you're going to use. We know that. That's why we're so thorough with that post-intubation exam. We want to make sure that our end titles are in place. We make sure that we have blood pressures every 5 minutes, especially blood pressures every time before I'm given a drug. We want to make sure that we're staying on top of those things, fluid boluses. May have to start a little bit of dopamine, which is going to be that adrenaline coming in, or you're going to be adding that epinephrine coming in and start to help on that alpha side and start driving that pressure and squeezing me down a little bit. Sedative and dissociation. So we use this for 2 categories right now, and we're just going to review why we use it right now. But ketamine can sedate or disassociate the patient depending on the dose and the route. And so right now, especially with our combative patients, it becomes very hard sometimes even for us to get close. We've seen a lot of times, we may have 6, 7, 8, 9 first responders trying to restrain a fairly small size patient, and the patient say, first of all, the patient's safety is number one. With us trying to subdue them, we could hurt them. At the same time, we worry about our first responders. We don't want our guys hurt. And so that's why we went to the ketamine when we did. So as we talked about before, the 0.5 milligrams per kilogram IV push only for entrapment. Okay, IV push only for entrapment. And I say that because we want to make sure that we have a patent line. That way, yes, they're trapped. How long have they been trapped? 20, 30, 40 minutes? Do we have compartment syndrome? Do we have, do we have such bad injuries underneath? We don't know. What about once we move, the leg is totally amputated and then I have a bleeding situation? I need to have that access, and that's why it's limited to IV push only at this point. We want to make sure that that the patient can communicate effectively. Extreme pain procedures or such as, and this is also be used for things as pacing. We're going to be adding it to our pacing protocol. The reason is a lot of times with the patient for pacing, it hurts them. And it hurts them bad because we're doing external pacing at that point. When they have the internal pacers, you don't see them sitting there going, ouch, ouch, ouch. But when I've sure got those little electricity outside, I've got to turn that ampage up a little bit in order to get that current to be able to capture the heart. That's going to be painful. A lot of times if somebody's got low blood pressure and I'm not able to get it up any other way, I don't have a lot of other medicines I can give them. I can give you a little fentanyl, but that has no sedative effect. The good thing about ketamine here, I get a sedative and I get a pain management effect from that. At the same time, I'm going to drive a little bit of pressure. I'm going to drive a little bit of heart rate. So I get a lot of benefits from it there. Once again, from the extrication, this makes our extrication pretty much painless at this point for the patient. We're able to sedate them. We're able to manage their pain by all the receptors that we're hitting. And then we're able to work with that patient and get them moved out. Next is we talk about for our dissociative side. And this is kind of the big thing. This is why we actually got ketamine to start with, was that it became so dangerous for the first responders a lot of times and for the patients with the synthetic drugs that are on the street. And it's what this does is we've talked about the 2 milligrams per kilogram IV push and the 4 milligrams per kilogram IM. I would venture to say a lot of our crews are end up using IM because we can't get them held down long enough to get an IV, get them restrained, get an IV in, get it secured, get the ketamine on board. We also know if I give ketamine very fast, what's going to happen? Apnea. And so I have a high risk of pushing that fast. Well, if I'm fighting somebody, I don't have 60 seconds to sit there and go do, 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 do. When I can get them down, get the 4 milligrams in, and then I've got the effect. And it may be the time when I can stick them and all the first responders just move. That way the patient's there's not a chance of the patient being harmed by us restraining. At the same time, it keeps the first responders safe if we can get away safely. Now, if we've got them in a good position and we got them held down safely, maybe the time just to set it out and ride it out. A lot of times when this situation, the heart rates are 160s, 170s, 180s, 190s, 200s from the synthetic drug, so it's absorbed very quickly. All that's being transferred very quick and absorbed very quick. So typically, within a minute, minute and a half, 2 minutes, that ketamine's done its thing. And so now we've got full control. Some of the things we got to remember, though, at some of the higher doses with ketamine is the involuntary arm movement. You may sometimes see the arms just come up, a lot of salivation. Have your suction ready at that point. Nystagmus, you may see the twitching in the eyes and stuff, and so you got to kind of be ready for those things. Usually these effects will last between about 30 and 40 minutes or so, give or take a little bit. The nice thing about the 4 milligram dose is actually a little bit safer for their breathing because it's going to be coming in a little bit slower. We know instead of than the IV push. Yes, I don't get quite that effect that quick, but if I'm able to manage that at that point, that may be the best way. A lot of stuff is even talking about the 4 milligrams per kilogram IM. It will allow that patient to stay sedated for a longer period of time. Sometimes now for us, with having a shorter transport, 10, 12, 14, 15 minute transport times, it's not that big of a factor for us. But if it's some of our county friends or some of our county cohorts, that may be a big thing for them, is they need to buy that extra 20, 30, 40 minutes, 50 minutes sometimes to get them to the next facility in order to facilitate a safe option after the ketamine. So what's new? Well, let's talk about the pain management first of all. A few changes. Once again, we're moving the fentanyl. It was over on the severe side over to the mild side. And it does give you an and/or option there. Okay, so we want to untie your hands a little bit more. So first of all, you've got your ketorolac or your Toradol at that point. Remember, that is an NSAID in itself, so platelet deaggregation, you got all those things that we've talked about before. But you've also said, okay, I've tried the minimal stuff. You know, I really didn't think this pain, man, my pain's growing. And we just talked about, remember, a lot of times those opiate receptors work in such a small area there. Okay, that's just not working. The NSAID's not working. Let me go ahead and add a little bit of fentanyl to it. It gives you that ability, once again, still 2 micrograms per kilogram to a max of 100, and you can repeat that up to 300 every 300 micrograms. But then on this side, we move to, okay, so we add a little bit heavier hitter, so we add a little bit of morphine to it at 0.1 milligrams per kilogram, IV, IM, or IO, however we can get a line or however we can get it administered. Once again, this can be given up to a maximum of 10 milligrams. Remember, with our opioids, though, we have an increased risk of apnea. Okay, that's something we have to, and nausea for that matter, so it's something we have to kind of play into. But if I've got severe pain, and you guys, you've been doing this long enough, y'all all know, you know, I walk up and I see somebody, you know, who's lost a leg, you know, you can only imagine what that pain is right there. You know, that's one of those, okay, let's don't do this unless, because I know I'm getting lots of effects here. This is for that very severe series. This is the one that may have fractured a leg, you know, they may be at a trampoline park, you know, and they're on the back corner of the trampoline park, because that's where it always happens, right? And so, you know, we have a severe fracture of the leg, and I'm about to have to carry them over all of these. Or it may be the car wreck in the ditch who got ejected, and now I'm going to have to, you know, hike them out of the canyon like they had to do the other night. And so you talk about these things, and this is why we're going to stay at that low dose at 0.5 milligrams per kilogram, IV or IO slow push. Okay. Once again, we're using this for pain management, and so we want to make sure that we have that ability. Typically with pain, we're talking about trauma. And so when we talk about traumas, you know, we always worry about hypotension. Now, we're firm believers here in permissive hypotension and letting them get to 90 and be okay with that, because we know we have less bleeding, a lot of benefits at the end of the day. And I'm not adding fluid to it and washing my H&H and messing with my platelet count. So we're big on permissive hypotension here. But at the same time, I've got ketamine, and I get pain management and dissociative effect. Even at that lower dose, it's still going to sedate them a little bit. So I get a lot of benefit from this, you know, because sometimes not remembering this could be a big blessing for them. And so it gives you an option to kind of untie your hands here. And this is for uncontrolled pain with severe trauma or hypotension. So if I've got something that's, you know, pretty bad pain, and I don't have any, you know, I don't have enough blood pressure to give them morphine, okay, then I've got ketamine here. At the same time, we want to make sure that we do not repeat this. And it also says if an opioid medication has already been given, we need to contact medical control. We start worrying about that synergistic effect. Remember, we talked about that opiate receptor has got the morphine in it. Now I'm going to be tagging the ketamine in with that, plus hitting the NMDA receptor. And so I'm going to get a synergistic effect. A lot of the literature very much supports this, but just till we kind of get feeling good about this and get comfortable with this ketamine, we'll still need to contact medical control. Those will be one of the few times that we ever have to contact. So as what I'm saying is try to judge that pain very well. And you know, there's going to be those times that we just miss it. There's going to be times, you know, hey, you know, they were sitting up in the car, you know, they were tolerating it pretty well. Well, then when I got them flat on the back, you know, or got them on the cot, and you know, I've got a horrible back fracture that we didn't know about because we don't have x-ray and MRI, MRA, and CT scan in the ambulance, and we get their legs flat on the cot. And so I gave them a little bit of morphine. I've tried that, you know, because they were managing pretty well there, and they were like, man, that really helped. And then I get them laying flat, you know, and then I'm straightening those legs. It's putting a lot of pressure on that lumbar, and it may get to where it's not tolerable. We still need you to call, just get medical orders for that one. But judge your pain. Try to size that up and say, you know, this is going to be a rough, difficult extrication. Let's go ahead and go with the big boy here. And that way I get the sedative and the pain management. So give you the discretion to do that at this point. Once again, as this is just highlighted a little bit more, this is uncontrolled. Once again, severe trauma, hypotension. This gives us, once again, it's still a little low dose. That patient at that low dose should be able to still somewhat conversate with you some. We just want to make sure that their GCS is staying good. Now, remember, I always got to worry about my head injuries too, and think, am I sedating a head injury? Sometimes I may have to sedate that head injury in order to get them out of that car because they're fighting so bad. They may have a half torn off leg, and I'm still fighting, trying to get out from underneath the dash. They're just got to understand we're just trying to help them, so we may have to sedate them at that point. Once again, don't repeat it. And this will be the max of 500 milligrams for us here, and at the 0.5, which should give you a very, very large range of patient weight for the 500 milligrams at this dose. Once again, remember that once ketamine is used, capnography is required. We want to make sure that just in case of another legal situation, the patient's breathing the whole time, and capnography is the gold standard for saying that that patient is breathing. Supplemental O2 is required once again. We do know they're going to be a little sedated. Have your suction ready again. They may salivate some. And if an opiate is used, has already been given, once again, just give the benefit of the doubt to medical control and ask for permission for that. So let's talk about the pacing. For a long time, we had the Versed and we had the fentanyl or. And you see or becomes a big thing here because you can't give it both because technically that's a constant sedation. That's not quite good. But if I get to my pacing portion, and guys, that's going to hurt. We've talked about that. I got to get my amps up in order to get that capture. That's going to be very uncomfortable for them. And a lot of times they don't have the blood pressure. We see a lot of times they're just giving fentanyl here because they don't have a blood pressure to do anything else with. And fentanyl's a great drug, don't get me wrong, but it only has that opiate property. If I've got the ability to give them an opiate and a little sedative in order to help that process, plus I'm going to get an increase in heart rate, I know that, and an increase in some blood pressure. So that may help me at the end of the day, once again at the low dose at 0.5 milligrams per key to a max of 500, and do not repeat. Once again, capnography is required for this patient. But once again, you still have that discretion. If the blood pressure is good, fine. And you're a Versed person, then go ahead with the Versed there. Just remember that Versed, that benzo could lower some blood pressure there, and I may not have that support from the heart to do that. Which ketamine, in my personal opinion, ketamine would be your best choice there. So let's talk about the reactive airway disease. We've talked about the properties of ketamine with it being a bronchodilatator. That's going to, and possibly a histamine blockade, and then a little beta-2 antagonist. So that's going to give us some good properties here for those respiratory patients. So this is the PAI protocol. So I've elected that I'm going to have to take that patient's airway in the field, and I want to put everything in my favor. First of all, if we're going to give one, we like to give it all here. Put it in my favor where I'm going to get them tubed, so we want to make sure we're going to follow everything through. But we give the ability, once again, first of all, with the head injury, we want to start with the 1 milligram per kilogram for head injury. Do not administer the ECG as showing a second degree or third degree block, of course, because we don't want to affect that with a lidocaine. At the same time, we come in and we still give the option for etomidate. We want to give you autonomy. We want to give you the ability to make these decisions. And 0.3 milligrams per kilogram to a max of 40 milligrams over about 20 to 30 or 30 to 60 seconds. But then we bring our ketamine into play. And so ketamine gives us an option here of saying, I'm knocking somebody down because of respiratory cause. I know the properties are good for it. Why don't we help them out immediately? Why don't we start, because you've already been doing everything you could. You've been trying to do an you've been trying oxygen, you're trying CPAP maybe, and nothing's fixing, so let's try something a little more potent. This will give you the ability, once again, 2 milligrams per kilogram IV to a max of 500. Now, we still need to give it fairly slow. We don't want to slam it, but what's the side effect of ketamine given too fast? Apnea, okay? What are we trying to create here? Apnea, okay? But then we want to go ahead and follow with our succinylcholine, or if they do have contraindications, succinylcholine, the Norcuron. We want to make sure we get everything in our favor, okay? If you're given one of these drugs, if you're given one of these two drugs, you need to go ahead with your paralytic, okay? Make it safe. Put everything in your favor. Yes, sex has a little bit of side effects that we always have to worry about, and we're conscious about that. But I do have the Norcuron in place. Remember, though, that if I've given Norcuron and I started with my etomidate, I need to be aggressive with a sedative soon, because my Norcuron is going to hang around 35 to 45 minutes, and that patient's not sedated. Remember, that has no sedative effect. It's all just a paralytic effect at that point. once again, at the higher doses, this is dissociative. And once again, apnea is the number one problem with that given too fast. So make sure you have your suction ready. So if you use it early, make sure you got suction ready quick, just like you would with any PAI. Make sure you got capnography ready and your ventilation equipment ready in hand and ready to go. This is the bottom portion of the PAI protocol. So this is our post-sedation or our post-intubation sedation protocol. Once again, you still have your choice between Versed, 0.1 milligrams per key IV, IO or IN to a max of 10, given that the blood pressure is above 90. Okay, guys, Versed is going to lower pressure. It is going to be transient. It's going to come back, but I've got that period that I've got to worry about with poor cardiac perfusion, poor cerebral perfusion, poor peripheral perfusion, so kidney perfusion. I've got to worry about those things at the end of the day. We also, if we like to give Versed, remember, we really like to give fentanyl with it. We like to marry those two together and let that opiate come in. That's 100 mics at the same time. So say if I get somebody intubated and somebody asked me the other day, well, why do we have IN here? Well, let me answer that, because a lot of times, what about if, you know, we're on a bad car wreck, they got ejected, we got them tubed with nothing. They were that far sedated or that far, the head injury was that bad. And then when I started getting them oxygenated again, I get a little bit of function, I start to bite. Well, I'm still working on my lines at that point maybe, because I took care of the airway first of what I'm taught to do, because the IV wasn't going to save them, but that ET tube sure was. So that's why we give you the ability right there. We use, you know, those two drugs, IN, so it gives you the ability to have some autonomy there and to say, okay, I can fix this quickly, I'll keep working on my line. Or option two, now guys, we've got a line right here and it goes to or. We have and or here, so both, but we have or here, and option two goes to ketamine. And this is where it goes back to the 2 milligrams per kilogram IVIO to a max of 500. We want to make sure that we're using that dissociative drug. Remember, it's going to last about 30 to 40 minutes. So I'm very safe if I have to reparalyze. Remember, we don't like to reparalyze in the field, but if we have to, there's going to be those patients that are going to need it, that I use my Narcuron here only, no succinylcholine for post-intubation, and at 0.15 milligrams per kilogram IV or IO, and that's going to give me a nice complement to this. So that will keep them paralyzed, and they're going to be sedated. Just remember to be looking for, you know, minute 20. Okay, so cut your half-life in half again. So about minute 20, I need to start looking for increased heart rate, tearing, maybe a clear clef on the end tidal. We'll see that way before I see anything else. Not always prominent, but could be there. And so this gives us the ability to take care of those patients post-intubation. Mainly for in the city, wow, that should buy you a lot of time. That should buy you a whole bunch of time, unless you're doing a long extrication. And it gives our county cohorts some room to have some autonomy and to have some time to be able to hands-free, where I'm not having to push drugs all the time with my Versed and fentanyl, which is going to be a repeated dose every about 10 minutes. Any questions?
If you use the ketamine prior to intubation,
yes,
and how long, 30, 40 minutes?
You're going to have about 30, 40 minutes.
Would you normally, are you expecting you're going to have to sedate after?
That's a good question. Typically, you would not have to sedate after. I mean, that patient's going to stay sedated for a long period of time. So it's not going to be like your Tominate. Remember that Tominate, right, about 7 minutes, about with your succinylcholine, right, it's wearing off. And that's why you'll see we get that secured, tube secured right now. We're going straight with our Versed and fentanyl. So this would give you a longer period of time of sedation. So, but you got to remember now you're adding your intubation time and you're getting right, everything secured. So that may cut, you know, it's still going to give you 30 to 40 minutes, but may not buy you as much post-intubation time. But yeah, it's definitely, you just keep looking for those same qualities. You may see the tearing, the heart rate.
So if we use ketamine prior to intubation, are we able to use ketamine again to maintain that sedation afterwards?
That's a very good question. So let's go back to that slide here real quick. Okay, here we go. So this is once again the post-sedation protocol like we're talking about, and it does give you the option to use ketamine up here. So you've come down, you've got them successfully intubated, yes. So I'm going to move it, because if no right here, I'm going to move over to my difficult airway and take care of the other issues. So this is once I have my airway secured and I'm needing to resedate them. Typically, yes, ketamine is going to hang around for 30 to 40 minutes. So chances of you having to resedate them with ketamine is probably decreased. But at the same time, we do know our drug population, that can be a big problem from time to time with them eating or chewing through, as we call it, chewing through our drugs very quickly. So yes, you can come in with your Versed or your fentanyl. We'd like to, remember, once again, give those two drugs together, but you do have the option of still coming back with ketamine. It is still safe at this point within the limits of going back with 2 milligrams per kilogram IV or IO, once again to a max of 500, and given that. So you will have that ability. This may be big effect for some of our outlying partners that once again are coming in and need to get those issues addressed long term. Very good question. Thank you. Any other questions? All right. Thank you once again for joining us at UMC EMS talking about our ketamine expansion, our protocols.